Now let's come to our subject, actually orthopedic sports injuries. And that's something where we never have the full picture. And if you look at these figures from the European Union, you see that actually we have 300 million of them per year, causing a budget, a healthcare budget of 78 billion. And this makes 7.8% of the entire EU healthcare budget. And that's similar to neurodegenerative diseases as Alzheimer or Parkinson and so on. And this is huge, but we don't realize it because we treat many small of those small injuries, just small pieces, but it's really a big cake. And actually we haven't calculated the long-term burden of sports injuries into these figures. That's also important to mention. And we also always say that sports is healthy. I agree with you, and I like sports. I do sports myself. But we lose, through the sports injuries, the financial impact. If we speak only about finances, we lose 40 to 50% of the sports-related healthcare benefits through the sports injuries. So you understand that I'm making a plea for prevention here. Now, if you look a little bit deeper now in our subject of today, the pediatric and adolescent athlete, you know these figures like here on the left, where you have these 14-year-old boys. They all have the same chronological age, not skeletal age. They have a very different skeletal age, actually. And that's one of the problems we face when we have pediatric ACL injuries. You have the 14-year-old boy on the right who has wide open growth plates, whereas probably in the guy on the left, the tall guy, who did not win the competition, by the way, has already closed growth plates. And you have seen the video on the right also. That's an adolescent girl. See how difficult it is for them to control their balance. So that's also something which is related to this period. I wrote a book on the pediatric knee a couple of years ago, and there we highlighted the pediatric ACL specificities. They are difficult to diagnose, much more difficult than in adults. We have no treatment consensus at all, you will see that. These kids have a high physiologic laxity. Those of you who have made the Lachman test in kids know that they have a normal AP draw of 3-4 millimeters. They have the presence of growth plates, which makes our surgery more difficult because we either have to get through them, around, or whatever. Knee growth is really specific. I will show you. The osteoligamentous stiffness is changing over these years. You know that in younger kids we have more bony avulsions of anterior cruciate ligaments, and then gradually we have the ligamentous injuries. In the very young, actually, that's something we described a couple of years ago, we have cartilaginous avulsions. So if you have a 5 or 6 year old who falls from a chair and has a big swollen knee, just rule that out with an MRI, not with X-ray, because you won't see that on X-rays. And then family history is very often positive in these kids who have ACL injuries. This is the growth chart. That's actually something each coach should actually have, because it's so super important. You know about the growth velocity and the growth spurt at around 13 to 14 years. 13 in girls and 15 in boys. Boys are a little later, as you know it. And this growth spurt is not coming from the lower extremity, as you may expect, but from the upper extremity, from the spine. And once this growth spurt is reached, they are in process of finishing the growth of their knee. So this is a very important period because it's the knee growth, the maturation period, where the knee gets stiff. And that's something you see here. I've superimposed 3 charts. The upper one is the growth speed chart you just saw, where you see that knee growth speed is going down at 13, 14 years in girls and 2 years later in boys. At the same time, we have the knee laxity, which is going down. So these knees get stiffer and get more difficult to control. And the lower chart shows you the explosion of ACL injuries we have in adolescents. These are figures coming from Sweden, from the Swedish registry, but all the others say the same in the world. So that's really a period where we have a problem and where we need to be very, very careful with these young athletes. So we have on one side, we have these pediatric ACL injuries with open growth plates, and that's the definition, which is kind of a rare disease. And the definition of the World Health Organization on rare diseases is that they have an incidence of less than 50 per 100,000 people. And then all of a sudden we go to an epidemic, not coronavirus, but ACL epidemic, which is then in the percent range. And we have understood in the last years that in these, I would say, 15 to 20 years old, we really have a problem because surgery doesn't seem to be the solution. 1 out of 3 of those kids has a second ACL injury, be it a re-tear on the operated side or a tear on the other side. And we have no clue why this is, why we are so bad at surgery and that at this age group. So if you look at statistics of re-tears of ACL reconstructions, and if they talk of 2, 3, 4, 5%, you don't believe it. This may be an overall re-tear rate, but if you look at the under 20, we are at around 15 to 20% everywhere in the world. So as I said before, we changed from an incidence in a percent range to an incidence in a per mil range in rather the other way around, from per mil range in the general population to percent range in these young athletes. This is a chart of our own ACL registry, an in-house registry, where we have in orange the male profile, the age profile of ACL injured patients, and in blue the ladies profile. And you see ladies have 2 peaks, one in adolescent and the young age, and one over 35. These are the skiing ladies in our area. You have many ski injuries in these female athletes who ski 1 week per year. On the left, we have the less than 5% pediatric ACL injuries. And we know that these young athletes, this is the age range where you have the highest or the quickest, the fastest increase in incidence. And these are data coming from Australia, from Chris Vertullo. And they also report very often on a positive family history. And that's something every family practitioner should basically know, but we don't know it. We don't even know it as specialists. We ignore this figure that 1 out of 4 has a positive family history, especially in these young kids. So there is something going on which we don't understand. Is it genetics? Is it something else? So there's room for science. And actually these figures are also known to the IOC. And for that reason, we organized this IOC consensus in 2017, which I initiated at that time together with Professor Lars Engebretsen. And I was lucky to be ESCA president at that time, together with Alan Anderson, who was AOSSM president at that time. And Alan unfortunately passed away a couple of weeks after this meeting. He was a great man. And here you see this IOC consensus was published in 4 journals worldwide. You can read it. It's open access. It was divided in 6 sections here, from prevention through ethics. Now, why ethics? We added ethics to this because we see more and more an ethical problem in the fact that many young kids who are under the age of 18 enter sports academies, sports schools, and so on. And when I gave a similar lecture, actually in France, to the French Handball Federation, they said, well, what should we do with a 14-year-old ACL injured kid? Should we keep him or her in the sports school? Should we dismiss him or her? I said, well, I don't know. We have no data. And I think the most important thing is that an athlete is not only a knee, but an athlete which is around. So I think that is not a reason to dismiss him. But it's something which challenges us and which should show that or emphasize the fact that we should do more prevention and also take care of these athletes from different aspects and point of views. And that's something we try to reflect in this ethical statement with our colleague, what's his name from Wales? McNamee, yes, yeah, great guy. So, and here's the problem. So we have too many of these mainly non-contact ACL injuries in young athletes. We have too many second ACL injuries. We know that these injuries have an important short and long-term impact on the life of these young athletes. Actually, what makes us fear these injuries as surgeons is that is the iatrogenic growth disturbances which may occur, and that's something which we expect or which we suspect to be higher than estimated. We have very diverse treatment algorithms and surgical techniques, so every surgeon has his own recipe. That's never good. Only half of the surgeons follow up the children until skeletal maturity. That's something which came out of the of a survey we made with ESCA, with Lars Engebretsen and Harvard Moxnes. And that's something which is not ideal either. And until now, there is no known case in the world of return to elite level pivoting sports after pediatric ACL injury. I'm not talking on adolescent ACL injuries, really pediatric with wide open physis. So, and that's, I think, the main message we as surgeons need to give to the parents when they come to see us with their children. Now, when do these lesions occur? We looked at, again, our ACL registry at home, and we found we kind of normalized the season in 3 ball sports: football, handball, basketball, over a year. And we found at the beginning of the season we had twice, and the incidence of ACL injuries was twice as high as during the rest of the season. Now, there may be many reasons of this, for this. We don't understand it yet. This is retrospective data, so we have to follow this up prospectively in order to get a better picture. What we know is actually that in these youngsters and in these young athletes, this is the population where it's highest, where the problem is highest. Now we move into a more surgical part of my lecture with some clinical pearls. If you have such an injured knee in a child, well, you need to make an aspiration. You need to do an MRI. Diagnosis may be challenging. You see here in the middle 2 videos. The upper is a 9-year-old boy with an ACL injury, and in the lower video shows his intact contralateral knee. But you see that AP laxity is pretty high in this case. And that's something you need to consider. And I had kids which were referred to me for pediatric ACL injury, and when we analyzed them and looked into on the other knee, the healthy knee and the supposed injured knee were totally the same. So you need really to be careful. And then we have, well, other pediatric pathologies which are very specific, like this sleeve fracture and others. MRI, as I mentioned it before, pediatric ACL injuries are more difficult to diagnose than adult ACL injuries, also because MRI is not as good as it is in adults. This has been shown over and over. Now, which is the current state when we have such an injured kid? So either we go for surgery, and then we risk malalignment and recurrent ACL injuries, or we go for nonoperative. If we not go for nonoperative, then we risk secondary meniscus tears and cartilage lesions. And when I say nonoperative, it's not to forget about the kid, but it's to really follow him or her up, and do regular exams, for instance MRI, I'll show you, as I show you later, and maybe change the sport. So if we go for surgery, we have the risk of malalignment due to surgical problems, 2%, or recurrent tears, 15%. If you do go for nonoperative, we have the risk of secondary meniscus lesions, and there's only now 2 studies from Norway, from Lasse's group, with 17% secondary meniscus lesions within 2 years. So what is the preferred choice of European surgeons? On the left, 60% choose to go right for surgery, and 41% have a more differentiated view. Where I would not say that surgery is not differentiated. Please don't misunderstand me. So my treatment algorithm is the following. If we have an ACL tear, and if we have a repairable meniscus or cartilage injury, then we go immediately for pediatric ACL reconstruction and do soft tissue repair, like meniscus preservation, which is very, very important. And here you have 4 of those situations. If we have a meniscal root avulsion in this 6-year-old, that's one of those kids who fell from a balance. The bucket handle meniscus lesion, that's often the reason for referral, but you always have to look if there is not an ACL injury hidden behind the bucket handle. Ramp lesions are increasingly getting a problem, or increasingly getting recognized in kids. Now we have here again the problem that they are difficult to recognize on MRI. and cartilage lesions, which we encounter also from time to time, but they are very rare, less than 3%. These were the indications for immediate surgery. Now, if we don't do immediate surgery, we go for non-operative treatment for 3 to 6 months minimum with a structured rehabilitation. That's the most important. Brace, I put it into brackets because there are no good braces for kids, and kids don't like them. And we have to do a close follow-up, which is for me an annual MRI, but also more, which I will tell you later. And I show you a case now here of a delayed reconstruction and a close follow-up. This was a 9-year-old boy who tore his ACL while skiing, and there was went for an initial non-operative treatment. One of the reasons was that the family was not pushing, which is so he was not a super athlete and so on, so we could wait a little. And he had no giving ways. We said, okay, well, we meet on a regular basis. I informed them on the potential giving ways, and if they have giving ways, they can get early into our clinics in order to check if there are some secondary lesions. And actually, at 4 years, we did an annual MRI. At 4 years, actually, we saw that there was something going on in the meniscus where we said, well, we have to keep an eye on it, but it should be okay. And that was actually the center of his knee. And here we have a PCL angle, and this angle is actually the line drawn through the posterior portion of the PCL, and it goes right into the femur. And you will see now the MRI 1 year later. That's what happened. The PCL goes parallel to the posterior cortex. And what does this show us? This shows that there is a kind of automatic anterior translation of the tibia. And if you see this, that shows that there is the load on the menisci, which are the secondary stabilizers. If the ACL is gone, that this load has increased. And we saw this, actually meniscal cysts both on the medial and the lateral side. So the menisci were suffering in this kid, and that's why we took him then to surgery. And this is a surgical view. That's a I would say non-natural view, because it's a view of the posterior portion, the posterior part of the knee, where I had to open up the capsule between the meniscus, and you see the meniscus is right here. That's the posterior meniscal wall. This is the femur, and here is the posterior horn of the meniscus. And from anterior, you don't see those lesions. So I had to open this, clean the cyst, and suture it back. That was the treatment. And on the lateral side, we had also to do kind of complex meniscal repair. That's how I do it, with absorbable sutures. And this is the ACL. You see here still the ACL stump, the graft. And that's the follow-up at 2 years. And this is a kind of, it's not a bullet, or a small bullet, or a shrapnel, whatsoever. That's a fixation device, an intraosseous fixation device, which works pretty well also in kids. And you see here, that's the MRI follow-up at 2 years. Menisci are totally normal, and the PCL angle has been normalized again. So we kind of prevented this boy to have what we call a knee decompensation. That's a concept which is not well known yet in the literature, and that's what we look at here. And that's the time between injury and decompensation. That's something we have to have in mind. And this occurred at the moment where his knees were close to maturity, so to speak. So now this concept of anteriorization of the tibia is very important to us, and that's why we introduced these lateral views, monopodal standing views. That's what we do. We do that. And then you can see if there is a spontaneous anterior translation of the tibia. And we do that side-to-side comparison. You see here, that was an ACL deficient knee and a normal knee. This difference is, there's actually no difference from one side to another. On this knee, you see that there is an ATT, an anterior tibial translation increase of 4 millimeters. And this is the other side. Now, this is an indication for surgery. There was a 15-year-old boy with physes which were close to closure, and that's why we decided to go, when I saw him, we decided to go immediately for surgery. And this is a concept we don't have very much in mind yet in our ACL reconstruction, also in adults. So we kind of ignore the sagittal plane. That's something to investigate in the future, Peter and colleagues. So That's basically what happened. If you do an arthroscopy in one of those kids and you go from flexion to extension, you see how the posterior horn of the medial meniscus is bulging anteriorly. And that makes it easy to understand that if the ACL is gone, the posterior horn of the medial meniscus is the secondary defense wall, the secondary line of defense. If this fails, the room is open for osteoarthritis. So that's what we do in a non-operative follow-up. We do the structures rehabilitation as described for the in the IOC consensus. We give rapid accessibility to specialized physio and medical care. If they are giving ways, they can come right away into our clinics. We do an annual MRI, look at the meniscal status and the PCL angle. We do lateral radiographs in monopodal stance of both knees. And we do annual laxity measurements in our laxity measurement station if the kids are tall enough. Now we know the goal is here to avoid knee decompensation and chronic laxity and wear out. So, otherwise, if this treatment, the non-operative treatment, is successful, let's say that the kid has changed from a level 1 cutting sport to a level 2 sport, which is easy in Scandinavia because they send them on the ski slopes, on the Nordic ski slopes, but we don't have those. So it's more difficult for us. We put them in the swimming pool, but counting the tiles in the pool is sometimes not so exciting for these kids. That's why they don't like it. So otherwise, so if the kids are grown out, we do ACL reconstruction at the end of growth period with an adult technique. And that's something we need, I think, more to implement more on a global scale, to have a thorough surveillance of those knees which we operate, but also those which we don't operate. So if we go for surgery, there are a whole bunch of surgeries which are described in the literature. That's never a good sign because that shows that there is no real good technique, otherwise everybody would do it. And so as I said before, every surgeon has his own recipe. Now basically you can divide the types of surgeries into 3 types. Either you drill your tunnel through the growth plate, through the physis, as here, that's the transphysial techniques. Then you can go around the physis, or you can stay within the physis, either on the femur or on the tibia. And that's what European surgeons do. So those who do the transphysial technique, there's no risk to go through the physis here, but we are a little bit more afraid on the femur. I will tell you why later. And those who use this, it's 10%, it's a minority. Now that's what we do, and 4-fold semitendinosus gracilis autograft. We use an extracortical fixation, very important, never fix something through the physis. The diameter always under 9 millimeters, 6 to 8 millimeters. And actually you see here, if you drill the tunnel on the tibia, you're in the center of the growth plate, and that's the first portion where the growth plate is closing. Now if you do it on the femur, you have a posterolateral tunnel. And this posterolateral tunnel is close to what we call the perichondral structures. That's the Ranvier zone. And this is a dangerous zone. Pediatric orthopedic surgeons know that. You must not injure this zone, otherwise you may have a growth abnormality. And if you have a growth abnormality on the posterolateral side of the femur, what happens? Well, the knee does this. I'll show you a case later on. So the preferred graft in ASCA surgeons is hamstrings in more than 90%. And we don't recommend the use of allografts in pediatric ACLs, or neither in adolescents. There are some countries where this is popular, but I think it's really a bad idea because allografts, and we know that, take 2 times as long as autografts to heal in. So why doing this in the highest risk population? That makes no sense. Now the gross complications, you saw them here. Well, I mentioned it before. You may have this valgus knee, you may have a varus knee, you may have a recurvatum knee, depending on where the growth abnormality occurs. And you can do many, many bad things in surgery if you do not control what you do. And here, that's a case actually coming from Japan. You see here the surgeon did an artificial graft through the physis. And that's worst case because you have a 3-dimensional abnormal growth, also in rotation, so that's what happens, and this takes like 1.5 years to recover with Elizarov and similar horrible techniques. Yeah, so be careful, don't do this type of procedures. And what about the outcome? Well, actually, we know that the evidence of treatments for ACL injuries in children is low. Again, a good study coming from Norway. And they have some specificity. So the results are good. They are so-so, but they are not as good as in adults. And sometimes you have incredibly stable knees, and you don't understand why, and sometimes you have the opposite. You see here, this was an incredibly stable knee, operation at year 11. And then what happened, so the femur grows and the endobutton grows up, it goes proximal, and you have a verticalization of the graft. And in adults, that's not what we like, because we make them more oblique now in order to control rotation better. But this kid had a really stable knee without any pivot shift and nothing. And so sometimes it's strange. And every pediatric ACL operated kid has some growth abnormalities. Usually they are clinically insignificant, but growth does not appear to be normal afterwards. And I show you here some abnormalities. You have seen already the upward migration of the femoral fixation. We have this verticalization of the femoral tunnel. We have, interestingly, a verticalization of the Blumensaat line, which is this line here. You see how oblique it is here and how vertical it is here. We have no clue what this means. And we have a relative thinning of the tibial tunnel. That's a very important message. So the graft does not get thicker with time. It's getting longer, but not thicker. And then what happens in the knee, and that's the next, actually you have the bone that adapts to a small graft. You have kind of an osteophyte here. And this seems also to stabilize these knees. So this knee was functioning very nicely, very well, despite or maybe because of these abnormalities. Now, what about graft incorporation? I mentioned it with allografts, but also with autografts. It seems to be a problem. It's something we haven't studied that well. This is one of the first studies coming out from the French Arthroscopy Society, where we looked at the signal of the pediatric ACL. And actually, it was shown that this signal was much more abnormal than in adults after a year or even 2 years after surgery. And this shows, and this is surprising because we all say that, well, kids heal faster, but obviously not in ligaments. And that's really an understudied aspect. And so we have to be careful here. And the message here is, if we operate them, keep them from the pitch for any longer, for a year at least. That was the conclusion of the IOC consensus because of this, because 1 child out of 3 had a second ACL injury. Now, what can we do to improve? We can do better prevention. Well, first of all, we need more epidemiological data. That's why we launched this pediatric ACL registry of ASCA. Now we have 8 or 9 centers participating. It's actually the first international ACL registry or orthopedic registry. Very difficult to get going in Europe because of the many legal barriers we had to overcome. We had these GDPR guidelines which were introduced in Europe, so data protection guidelines, which were really a problem, but we were getting there. Now, what about doing better surgery? Well, maybe lateral extraarticular tenodesis in kids is an option. I've never used it. There's no data to support it in kids, so we could give it a try. On the other hand, graft choice may also be good. Here you see a quadriceps tendon graft, and we have data coming from Houston now, new data from Walter Lowe, who has a fantastic series in pediatric ACLs with quadriceps tendon grafts. These grafts are stiffer, and they may be more stable than others. What about ACL repair? In kids especially. This has been promoted and is being promoted, and that was when I spent some time at HSS this summer with the ASCA AOSSM Traveling Fellowship. And while we were there, in the New York Times, there was this article which came out. And these are the sports medicine guys here. You see Dr. Ranawat and Dr. Marks and others, big names in orthopedic sports medicine. And we told them, why is this coming out from HSS actually? And it was not coming from their group, but from another group. So about ACL repair in kids, and if you see this, you say, wow, this is great. My kid doesn't need a big operation. So we put in kind of, what is it, a shoelace through the graft, and it will heal. Well, that's not really true. And actually, these guys were really upset. And so they made a counter statement and so on. But that's currently what's going on. We need to be careful. An ACL repair is not the solution, at least not in children again. Why doing a minor surgery in the most risky population? What else can we do? Well, we may be doing better meniscus reconstructions, also in children. That's something we have learned in adults over the last years. In my hands, we have in 75% we have now ACL-associated meniscus repair, and I will go a little bit deeper into this. Do we still have time? Yes, I think so. So over the last years, we have discovered these holes in the posterior capsule. We call them ramp lesions on the medial side. On the lateral side, we have understood these meniscus injuries much better, and we know now that they are important also for rotational control. And we have some instabilities which we also underestimated. So the lateral meniscus has really very, very complex, we could call it suspensory mechanism, with lots of ligaments going around, and they can be injured, and that's something you don't see on MRI, and it's also very difficult to diagnose in arthroscopy. So that's why we have to do efforts to understand this better. And we know, for instance, for the ramp lesions that they don't heal without repair. So you see here a very big hole in a 14-year-old football player, and you see here, this is a video from this surgery. See the hole here? That's a posterior view. This is the meniscus, this is the tibia. You see nicely on the tibia if this is broken, and what we have to do is really to grab the capsule and put it back to where it was torn off. You see over there. If you don't do that at surgery, that's a problem. And this is like shoulder surgery, where we do the same for banquet reconstructions. And these are lesions you don't see from the anterior part. So if you do your classic arthroscopy from the anterior side, you don't see that lesions, and you have really specifically to go to the back to discover them and to repair them nicely. Now again, these are data from our ACL registry, where we found actually these new lesions, medial ramp lateral root and medial ramp and lateral root, in 1/3 of our patients. And this is a lot. So 1/3 of meniscus injuries have been missed in the past. And so that's important. So what happens in these knees? This is probably the most well-known ACL injury, with the nice poster software building a skeleton on it. And I thank Trond Krosshaug from Norway who gave me this video. And if you look at the knee, this is not an ACL injury, this is a near knee dislocation. You see, that's nearly a knee dislocation. And that's something which we kind of do not differentiate. So for us, an ACL injury is an ACL injury. No, that's not true. We have an ACL plus, isolated ACL, ACL plus, 1 meniscus, 2 menisci, and so on. And that's something we need to understand much better and to classify much better, and also to understand the outcome much better. Because sometimes if you do an ACL reconstruction in one of those patients and you don't look for the meniscus, you don't look for associated injuries, you must not be surprised that he cannot make it back to sports. And this has been nicely shown, these knee subluxations, in some studies who superimposed actually the bone edema on both the femur and the tibia. And they found that there is, in many of those cases, you see here 25 to 65% of the cases, you have a 25 millimeter anterior tibial translation at the moment of injury. Look at this, a 25 millimeter. And then how can you imagine that it's only the ACL that tears? So we have to take into account the whole complexity of lesions which get injured at the moment of injury. You have to understand this much better. And I'm dreaming of a kind of MRI software showing us this figure on the super right in order to show us what was the amount of displacement of the knee at the moment of injury. And actually we looked again into our data, and we found, this is non-published data, we found that actually there seems to be a correlation here between the amount of structural damage. You see here partial ACL injury, which are the ones we don't operate, and these may be the ones where others do what we call an ACL repair, but maybe you don't need surgery in these patients. And then you have complete ACL plus 1 meniscus plus 2 menisci, and then also other associated injuries like the anterolateral complex or the posteromedial complex. And this seems to correlate actually with the amount of pivot shift which we do under anesthesia, and we put these data together and found these nice figures. So let's come back to the kids. Here we know again that Actually, these meniscus injuries are more frequent than suspected. We have many of those new lesions also in kids. And so there is this association between meniscus injuries and delay of injury to surgery, which is reported in literature. So many surgeons say, well, if you wait too long in these kids, of course, this is going to happen. But is it a causal relation, or were the meniscus lesions, were they there from the start and so on? We still don't know yet, and we have to understand this much better. And so far, we have no proof that ACL reconstructions prevents additional meniscus damage. We don't know that. It could be that, and I showed you many white spots in our knowledge through this lecture. It could be that, well, we have to understand this better. We have to avoid knee decompensation, a concept which needs to be, I would say, more backed up by science. But you saw here in one case that it is, there is something in it. We have to save this menisci, and we have to do more prospective studies. Now, the 5 things I've learned over the years is that there are too many pediatric and adolescent ACL injuries. This is the fastest growing age cohort of ACL injured patients. We have to protect them. There's a natural history of growing and ACL deficient knees. This is still insufficiently understood. We know that surgery is safe. We have established safety procedures intraoperatively. But I'm still not sure if surgery is the solution to all of the problems, and you have heard why. In my opinion, there's no return to elite level cutting sports in children after ACL injury or surgery. And again, so I'm not sure if surgery is the solution here. And we need to have better follow-up data. And if you have one of those kids which did it, please publish it. Prevention is key, that's the last message. So this is my team from Luxembourg. Many greetings from there. And I would like to invite you to 2 conferences. This one may not happen because of Corona. We don't know yet. So we are a little bit stressed here, the ESCA Congress in Milan. And I hope that in January 2021, this will be over, and then you can come to Luxembourg to the Meniscus Conference, which is the, I would say, the only worldwide conference that's specifically dedicated to the meniscus. Thank you for your attention.